Good afternoon, everyone. My name is Brandy Sims. I'm a program officer with First 5LA and a representative of the AAIMM Initiative. Thank you all for joining us today. This webinar on preeclampsia will begin promptly at 2 p.m. As folks are entering the room, I'd like to share a little bit of information about the AAIMM Initiative, as well as some housekeeping requests. AAIMM, or the African American Infant and Maternal Mortality Prevention Initiative, is a county-wide effort co-led by the Department of Public Health and First 5LA in partnership with a wide range of public, private, and community partners. Our goal is to reduce the rates of Black infant and maternal mortality within LA County by 30% within 5 years. Currently, Black women and babies in our county die at 3 to 6 times the rates of those of other races, primarily from complications related to preeclampsia, eclampsia, and preterm birth. Previous efforts to explain this disparity focused on the behavior and characteristics of the mother, but research shows that prenatal care, abstaining from smoking, and other factors are not protective for Black women. Research shows that the cause of these disparities is the chronic, toxic stress of racism, which has a weathering impact on the body, resulting in a range of poor health outcomes, including preeclampsia and preterm birth. We are glad to be able to elevate the voices of Black women physicians, policy and systems change agents, and those that have experienced preeclampsia in today's webinar. We'd like to thank the Association of Black Women Physicians for your partnership in bringing forth this training, and the March of Dimes for your financial sponsorships of CMEs and CEs provided through PACLAC. You can learn more about the AAIMM Initiative and future offerings at our website, blackinfantsandfamilies.org. And now to housekeeping. This webinar is being recorded. Please use the Q&A box for your questions throughout the session, and we will address them at the conclusion of the presentations. The chat box will be used for comments and discussion. There will be a feedback form shared after the session, and this brief form will need to be completed before CMEs and CEs are credited. And with that, I'd like to hand it over to Dr. Sylvia Swilley from the Association of Black Women Physicians.
Good afternoon, and welcome to Overcoming Disparities in African American Infant and Maternal Mortality. I'm Dr. Sylvia Swilley, co-chair of the Association of Black Women Physicians, ABWP's Advocacy Committee. As physicians, mothers and mothers-to-be, grandmothers, godmothers, and aunties, we too are victims of the disparities that affect all Black women in our community. Our organization readily embraced our president, Sylvia Gates Carlisle's decision to make combating African American maternal and neonatal mortality a signature part of her platform. We join with AAIMM and the March of Dimes in addressing this critical issue. This is the second in a series of webinars dedicated to educating physicians, nurses, other providers, and the community at large about the morbidity and mortality of African American women related to childbirth and the disparate loss of African American infants in the first year of life. The first webinar in the series lent focus and attention to implicit bias and racism as the primary drivers of these disparities. Today, we turn to preeclampsia. The agenda will include 2 presentations on the medical aspects of preeclampsia, a personal story of a Black woman who suffered preeclampsia, and a presentation on local data and the March of Dimes preeclampsia resources and strategies to increase community and provider awareness. Disclosure information as required for CME certification is provided on the next slide. Again, I invite you to put your questions in the Q&A, as our presenters will be available to answer your questions at the conclusion of the presentations. Our first presenter is uniquely suited to address the issues of preeclampsia. Dr. LaTanya Hines is a practicing obstetrician gynecologist, a partner in the Southern California Permanente Medical Group, and an assistant clinical professor at the Kaiser Permanente School of Medicine. Dr. Hines will speak on the importance of preeclampsia and its impact on maternal mortality and morbidity in the African American community. No one is more qualified than Dr. Carol Watson to speak about the long-term cardiovascular effects of a diagnosis of preeclampsia. She is the director of the UCLA Barbara Streisand Women's Heart Health Program and the UCLA Women's Cardiovascular Center. She will discuss the cardiovascular implications of adverse pregnancy outcomes. No academic discussion of preeclampsia can bring into clear view its human toll. The stories of women who have experienced preeclampsia need to be heard. Chanel Gibson is an award-winning writer and television producer, preeclampsia survivor, and maternal and child health advocate. She lost her 4-month-old daughter, Isabel, to complications of prematurity earlier this year. Mashariki Kudumu is the maternal and child health director of Greater Los Angeles for the March of Dimes and a member of the AAIMM Countywide Steering Committee. So let's begin. Dr. Hines.
Good afternoon, everyone. And ready. So this afternoon, we're going to be speaking about preeclampsia and the importance of its implications on the African American community, but specifically for African American women and their children. I'm hitting my button, just a second. There we go. I'm not going to read my slides, but they are absolutely available to all of you. And I want you to know that if you would like to have discussions in further detail, please put that in the chat. But my job today is to give you the skinny on what we think is the etiology and evidence-based research on preeclampsia. Effectively, we're going to discuss treatments for patients with preeclampsia, discuss the importance of early risk factors in the African American community, and to understand the preeclampsia and the impact on future cardiovascular risk profiles. Understand that preeclampsia is an important risk factor for severe mortality and morbidity in the African American community, and that how could we potentially mitigate some of these factors in future pregnancies. I'm going to put myself a little smaller. Perfect. This slide is depressing. Unfortunately, it is true. African American women are 3 to 4 times more likely to die from pregnancy-related causes than non-Hispanic white women. The disparity in maternal death defined within 1 year of pregnancy caused by a pregnancy complication or a chain of events initiated by pregnancy or the aggravation of an unrelated condition by the physiological effects of pregnancy. This has existed for over a century and has actually widened over the last 100 years. African American women have had the fastest rate of increase in maternal deaths between 2007 and 2014, and in certain cities have a maternal death rate upwards of 12 times higher than non-Hispanic white women. Our job today is to learn the tools and to implement them in order to significantly reduce this incidence. What are the risk factors for preeclampsia? Twins, multiples, prior pregnancy with preeclampsia, renal disease, autoimmune disease, type 1 or 2 diabetes, chronic hypertension, and that last word should just say racism, but socio-demographic factors for preeclampsia and personal history factors. These are some things that people are not aware of to some extent. The first pregnancy, perhaps the first pregnancy with a male child, maternal age greater than 35, body mass index greater than 30, which is the definition of obesity, and once again, family history personal of preeclampsia. Defined, there are 4 categories: gestational, chronic hypertension with superimposed preeclampsia, and preeclampsia eclampsia. I decided that a slide was better than the narrative. If the patient's blood pressure is greater than 140/90 on 2 separate occasions, at least, it used to be 4 to 6 hours apart. This came from ACOG, which is our board certifying agency that says greater than a week apart. After 20 weeks in pregnancy with a history of previously normal blood pressures, that meets the criteria. If the blood pressure is greater than 160/110, and it's confirmed with a repeat blood pressure in a similar range, that too is considered to be preeclampsia, technically at any time in the pregnancy to some extent if they don't have chronic hypertension. And that is also an indication for immediate intervention with medication. Proteinuria is defined as spilling protein in the urine. There are some of the criteria here that certain hospitals use, but we have decided to use an easier one, which is protein creatinine ratio. That is the latest way we do it. And if it's greater than 0.3 milligrams per deciliter, that is considered to be preeclampsia. Now, there are lots of other reasons, and we will go through those in these slides, but specifically, protein creatinine ratio greater than 0.3, blood pressure greater than 140/90 on at least 2 separate occasions, in a patient who does not have a previous history of preeclampsia at minimum 20 weeks pregnant. There's the diagnosis. Now, in addition, there are other criteria that you can use, which to some extent foretell a more severe illness. Thrombocytopenia, which is the platelet count less than 100,000, renal insufficiency, which is measured by serum creatinine greater than 1.1 milligrams per deciliter, impaired liver function, which in your lab at your hospital, if it's associated with double the AST or ALT for the standard levels, and you can't see it on the slide, but pulmonary edema, which presents with shortness of breath or decreased oxygenation on room air. The classifications: preeclampsia with severe features, as we went over just a little bit there. And this is all, to some extent, one of our pioneers in obstetrics with Dr. Sabai. I believe he's still in Texas. And this comes from his study in 2004. In addition, where many of our colleagues will talk about this as family practitioners and other physicians who are not OBGYNs, is they will tell their patients about visual changes, headaches, and blurred vision. Headaches are a very common side effect or symptom in pregnancy. They can be related to dehydration, they can be related to stress, lack of sleep, you name it. But a headache in association with elevated blood pressure, abnormal swelling, decreased urine output with the other symptoms is definitely preeclampsia until otherwise proven. There's also an association with right upper quadrant pain, which we believe is associated with swelling of the capsule on the liver. Growth restriction, that's in the fetus. And that can present sometimes a lot earlier than you would suspect, sometimes around mid-pregnancy. And then pulmonary edema, even without severe symptoms, is significant. So the classifications, I talked about that just a couple slides ago. What is gestational hypertension? It is just elevated blood pressure, which is, there's no such thing as just, but it is elevated blood pressure greater than 140/90 without any of the other symptoms. A basically asymptomatic patient with normal lab values. That's gestational hypertension. Preeclampsia, I just defined it. That's the 140/90 with all the other criteria. But here's the one that's tougher. Chronic hypertension that precedes the pregnancy. So that means that the patient started the pregnancy with a history of elevated blood pressure. We would define that as essential hypertension. Sometimes we know why. Most of the time we don't. I would say being Black in America is probably the biggest risk factor. But in addition, there are kidney disease issues, autoimmune disease issues, lots of other problems that can be associated with contributing to chronic hypertension. So when those patients enter into the pregnancy, they already have one significant risk factor, which will potentially be associated with an increased risk of acquiring the disease. Next is the severity. We talked about that to some extent. If your blood pressure is greater than 160/110, that's severe. You don't need any other reasons. That gets repeated in approximately 10 to 15 minutes. And if it's still that high, you get treated. Depending upon what stage in the pregnancy you're in, it's the difference between whether we need to intervene and deliver, whether we have time to buy, or whether we need to potentially, regardless of mother, I should say fetal status, we might need to go ahead and deliver that patient, because this is what I say, or what I call a mama disease. This is a maternal issue that has a significant impact on both mama and baby. Prevention. Now I say this kind of tongue in cheek because it's kind of hard to prevent, but there is some working research on what we can do to mitigate a lot of the symptoms. So if the history of the pregnancy of preeclampsia in a previous pregnancy, history is important. What you did once, potentially, you can do again. If the patient is less than 34 weeks, why is 34 important? Because 34 weeks is associated with lung maturity. So at 34, although we don't want to deliver at 34 weeks, if a patient is 34 weeks or less, we are going to give them aspirin, but let me start and say this. Aspirin is given between 12 to 28 weeks to have its best effect. And it is not stopped at 36 weeks, which the most recent study, probably about 5 or 6 years ago, talked about. We now take aspirin all the way through the pregnancy. It does not increase the risk for bleeding or abruption, which are conditions in pregnancy that are associated with bleeding. An 81 milligram dose is what we're using, although the research shows that we were using about 150 milligrams. So this is a really tiny dose. How it worked, I'll go into later in the slides, but it is an anti-thromboxane, anti-prostacyclaglandin inhibitor. So vitamin C and E, folate supplementation, I add that because I want people to know that it is important to have folate supplementation to reduce the incidence of urotube defects. Vitamin C and E are not bad, but they have not been shown to be evidence-based risk reducers for preeclampsia. Neither has calcium, unfortunately. So if you do have calcium low stores, you should take it, but it's not necessarily associated with a decreased incidence of preeclampsia. Bed rest and salt restriction is also not, let me say that again, not associated with a decreased incidence of preeclampsia, yet patients who enter the pregnancy with chronic hypertension already know that they are likely salt sensitive. And that means that the reason why they may be associated with having chronic hypertension is a high salt diet, besides other mitigating and perhaps genetic predisposing factors. Bed rest is also absolutely not associated with decreasing preeclampsia. It's actually associated with an increased risk of deep vein thrombosis because of a hypercoagulable state in pregnancy. What do all these fancy words mean? If you lay down in pregnancy, you clot more, or you're at increased risk for clot. So not only do you increase, or I should say you increase your risk for clot and the complications with that, but it does not do any increased, it doesn't help preeclampsia. So that's important to put some of those fallacies down. So we're going to get into the nitty-gritty of it. It is a multi-system progressive disorder characterized by the new onset of high blood pressure and protein in the urine, high blood pressure with end organ dysfunction, as we talked about with liver enzyme elevation, serum creatinine or kidney function decrease, and it happens when? In the last half of the pregnancy. The disorder is caused by placental and maternal vascular dysfunction. It always resolves after delivery. I want you guys to see that that's a typo. Always is never absolute in medicine. It should and likely will resolve within the 6 to 8 weeks after delivery, but I've certainly seen, and it is in the literature, that it may not. And if that's the case, more than likely we're looking at someone that had underlying chronic hypertension, and perhaps we were misdiagnosing them with preeclampsia. Although most effective pregnancies deliver at term or near term with good outcome, these pregnancies are at increased risk for maternal and fetal mortality and serious morbidity, which means illness. In addition, women with preeclampsia are at increased risk for future cardiovascular disease, and we will hear more about that from Dr. Carol Watson. This is important. The precise mechanism of preeclampsia is unknown. We believe that it involves maternal and fetal placental factors. The major component in the development of preeclampsia is the excessive placental production of antagonists to both vascular epithelial growth factors and transforming growth factor B. Let me just break that down. It means that when you have a diagnosis of preeclampsia, it started from the start, from the beginning. When the egg and the sperm met, created the embryo, came down the tube and implanted in the uterus right there. And as those special cells called trophoblasts dug deep into the lining of the uterus and searched for good blood supply to create a placenta to give good nutrition and oxygen to the baby, there was the problem. They didn't dig deep enough. They didn't get good blood supply. And as the baby starts to grow larger and larger and demand more and more oxygen and nutrition, you will start to see growth restriction and the subtleties associated with preeclampsia mid-pregnancy. By the time you get to the end of the pregnancy, it is significant. Although the diagnosis was made at the end of the pregnancy, this process, as you can see, had been going on all along. There does appear to be a heritable component in oxidative stress, and abnormal placental implantation can also further increase the risk of developing the disease. And here's what I just talked about. Is there a genetic predisposition towards preeclampsia? Perhaps. Is there an abnormal immunological response? Perhaps. Deficient trophoblast invasion, fancy term for as the placenta starts to form. Is there a vascular, as in blood supply issue to the baby? If the placenta can't deliver good blood supply and oxygen to the baby, what do we end up with? A smaller baby. And part of that whole process with the vascular endothelial cell activation, the generalized vasospasm and narrowing of the vessels, the activation of an increased risk for bleeding with coagulation system problems, and altered thromboxane. Remember what we said about aspirin? Here is a level at which it may help. What does it do in total? Reduce uteroplacental blood flow. That's just a fancy term for no matter what you're doing, mama can't get enough blood supply and oxygen to the baby because the blood vessels are spasming with lots of other mechanisms behind why that happens. So what do? We see the clinical, that's the physical manifestations of the disease. Postpartum, we thought we were safe, right? We got you to deliver, but it can occur up to 6 to 8 weeks after delivery. Recognize it early, and that means headaches, blurred vision, right-sided abdominal pain, elevated blood pressure. Go to the ER, please. Don't mitigate it and think that perhaps I was done with that with my delivery. Please go, because the same sequela associated with a severe outcome can still happen after you've had the baby. We do and have instituted certainly throughout California and through the Kaiser system, immediate postpartum patients who've had a history of preeclampsia should be seen within 3 to 7 days for blood pressure checks and medication management as necessary. They also go home with their own blood pressure cuff. They know the risk factors, they know what the signs and symptoms are, and they are to call us on L&D 24 hours a day or go to the ER for evaluation. Readmission entails magnesium sulfate. We use that as a method to raise seizure threshold and decrease the likelihood of having eclampsia, which is preeclampsia with seizures. Using magnesium sulfate, which is a very mild vasodilator, but that's not why we use it. We use it in order to keep you from having a seizure when your blood pressures are so high and uncontrolled. Delivery, that's treatment. Get the baby out. The problem, though, is that the risk of prematurity associated with preeclampsia can sometimes outweigh the mild or moderateness of the disease. Let me explain. If you're greater than 37, let me say this. On my license plate, it says 40 weeks. That's your due date. But 38 weeks is considered full term. And you can go all the way up until about 41, 42 weeks before we start pulling our hair out about why you're not delivered. But 37, certainly you could be delivered. If your blood pressure is greater than 160/110, please deliver. If it's greater than 140/90 persistently, deliver. It's easy, deliver. Here's the sketchier part. If you're less than 37 weeks, but greater than 34, remember I talked about lung maturity? That little area right there, without severe symptoms, you can kind of wait a little bit and see if you're getting good growth. And during this time period, those patients are getting non-stress testing. They're getting a lot of higher level of surveillance in order to make sure that we are waiting, knowing that we're still going to get good outcome. We also have them with the high-risk OB professionals where they were looking at what we call Dopplers, which is middle cerebral artery evaluations and making sure the baby's still getting good blood supply and oxygen and good oxygenation to the brain. If they're unstable, maternal or fetal, if the mother looks like she's gonna have a stroke or has had a stroke, God forbid, or detached her retina, or the baby has significant evidence of what we call uteroplacental insufficiency on the fetal heart rate tracing, deliver. And that is regardless of gestational age. It does not sound good, but it is a creed of the OBGYN professional. We can always make another baby, but we can't make another mom. That doesn't sound great, but that is the creed upon which we work to save both. But if we got to make sure that the mom is doing well, because otherwise we don't get a good baby. Magnesium sulfate, as I talked about before, for seizure prophylaxis. And there's also an addition with 6 grams of magnesium sulfate if you believe you're going to deliver the patient within a short period of time, basically within 24 hours, for neuroprotection. And that has been shown to decrease some of the severities of prematurity and the incidence of neurological abnormalities using magnesium sulfate. These are some of the same things we talked about. When should you deliver? And these are the also risk factors for preeclampsia to some extent. So future thoughts. Women who did not develop preeclampsia in a prior pregnancy are at only 1 to 2% risk of spontaneous preeclampsia in a current pregnancy. What does this mean? Everybody is at risk, but there are those who are at higher risk. And who are they? African American women and women of color. Women without preeclampsia with severe features near term have about a 5% chance of developing it again. And I've seen this in many of my patients anecdotally. They have it severe in one pregnancy, but the next one they don't. But women with very severe features have an approximately 25% chance of redeveloping it. And if they delivered with that particular severe outcome before 30 weeks, they have upwards of a 70% chance of recurrence in future pregnancies. That is very important because some of those risk factors perhaps are associated with chronic underlying hypertension, obesity, diabetes, inherent renal dysfunction. Very important that those patients know that that's a planning of a pregnancy that needs to happen, as opposed to just getting pregnant and hoping for a good outcome. Final thoughts. Preeclampsia, the syndrome, is disproportionately higher in African Americans. It is associated with a higher risk of comorbid conditions like hypertension, diabetes, and obesity. One of the main causes of illness and death in African American women in pregnancy, specifically for pulmonary embolism and hemorrhage. It's defined as blood pressures greater than 140/90 at 20 weeks or greater gestation in a non-hypertensive patient. That's someone who did not have a history of elevated blood pressures before. Severe preeclampsia is defined as 160/100, period. Delivery is definitive treatment based on the severity, maternal and fetal condition, as well as the gestational age. Preeclampsia is an absolute risk factor for future cardiovascular disease. And unfortunately, the cause of preeclampsia is unknown. These are my references. And those are my 2 preeclamptic babies. My son, who is now 22, and my daughter, who is 20. I thank you for listening.
Thank you so much, Dr. Hines, for giving us such a really showing us the landscape of hypertension. And now a perfect segue to hear from Dr. Carol Watson.
Thank you so much, everyone, especially Dr. Hines for that wonderful introduction. I'd like to talk about the long-term consequences of preeclampsia because I'm an adult cardiologist and that's what I see. And I really appreciated Dr. Hines saying, usually it's once you deliver the baby, it's done. I actually see a lot of women who it's not done after they delivered their baby. These are my disclosures. And again, I said pregnancy is that stress test for the heart. As women, we really don't have a lot of physical and metabolic cardiovascular challenges, much like pregnancy all in one, and that can unmask vulnerabilities to cardiometabolic risk, like hypertension. And you saw this slide or something similar from Dr. Hines. I want to make this very clear to everyone out there. There's nothing that we do as women that's going to cause our preeclampsia. It's not our fault. It's not the salt we eat. It's not the weight we gained. It's not the exercise we didn't do. There's probably a genetic component. There's abnormal immunologic response. And as Dr. Hines mentioned, those cells that are supposed to dig deep into the endometrium to start the placenta that feeds the baby doesn't necessarily happen the way it's supposed to. So the placenta is deficient. And I'm going to keep coming back to that because in my cardiologist simplistic mind, the placenta is a big bag of endothelial cells whose sole job is to support the growth and development of the baby. And if it does not do that, that's telling us something bad about the endothelium. The endothelium then can produce these circulating factors and activation that cause disease, like hypertension. I really want to focus on the endothelial cells because endothelial dysfunction, I think, is really at the heart of many pregnancy-related diseases like preeclampsia. It's also at the heart of most of our cardiovascular diseases. So preeclampsia, I think of as a disorder of the vascular endothelium. As you heard from Dr. Hines, unfortunately, it's not an equal opportunity disorder because Black and brown people are much more likely to get preeclampsia. We always think of preeclampsia in terms of hypertension because that is the sine qua non, but that's not it. I remember being in medical school and learning that exactly as Dr. Hines said, the treatment for preeclampsia is to deliver the child and then the hypertension goes away. Whew. But the more we know, the more we see that's not true. So if you look at women who have a history of preeclampsia, the red line there, compared to women who don't, there's a significant and very early increase in the risk of hypertension. If we think of the average woman as having a baby around the age of 30, you can see that within a year, you start to see increased risk of hypertension. So what we're doing now is not causing disease or anything, but we're probably unmasking a vulnerability to hypertension that's probably always going to be there. Some people may get it early, some people may get it late, but if you have a history of preeclampsia, you're likely to get it much earlier. I'm going to show you some data on outcomes, long-term outcomes after a history of preeclampsia in women. And this is a study that's from the British Medical Journal. It's a systematic review and meta-analysis. And it really did look at a large number of studies and women, over 3 million women, a lot of them affected by preeclampsia and a lot of them not. But what we have to see is what are the outcomes in the women who had preeclampsia during pregnancy if we follow them years down the road. So this is from that study looking at the risk of future hypertension in women with preeclampsia. And all the studies go directionally in the same direction, showing that if you have preeclampsia, you have an increased risk of future hypertension, and it's almost 5-fold increased risk. As I showed you, that risk starts very early. You start to see those curves diverge really in the first year. So what preeclampsia really is telling us is there's probably an underlying vulnerability to hypertension, which will manifest later in life, and we just don't know when. So we have to watch these women very, very, very closely for the rest of their lives. This slide shows the risk of future ischemic heart disease, heart attacks, in women with a history of preeclampsia. As you can see, there's again an increased risk. So the risk is about 2.2-fold increased risk in women with a history of preeclampsia. This is again something we know. If there is underlying endothelial dysfunction, then the endothelium covers every single blood vessel and every single organ. So the vessels that supply blood to the heart can be impacted, such as the blood vessels that supply the placenta. This is data on future stroke or venous thromboembolism in women with a history of preeclampsia. And again, you see that there's an increased risk of almost 2-fold if a woman has a prior history of preeclampsia in both stroke and venous thromboembolism. And what about everything else? Is it just a marker for future illness of any sort? No, it's really vascular illnesses. So if we look at the future risk of cancer in women with a history of preeclampsia, there's nothing there. It's right along the line of unity, meaning no increased risk, no decreased risk. But that's what we would expect if we're dealing with an underlying vascular disorder, which preeclampsia is. All right, now it's a lot of different vascular disorders. I showed you heart attack, stroke, and venous thromboembolism, but remember the kidney is also a big ball of endothelial cells, the glomeruli. So chronic kidney disease is also a disorder of vascular endothelium. And you can see over there to the left that there's an increased risk of chronic kidney disease in women with a prior history of preeclampsia. That's the red line, as compared to those without. That's the blue line. And again, if we think about 30 years of age as the age that most women, the average age that women deliver a baby, you can see that risk of increased chronic kidney disease happens about 20 years later. So you're starting to see that manifest at about age 50 or 60. Let's look at congestive heart failure there. Again, one of the biggest risk factors for congestive heart failure is hypertension. So it does not surprise me that you start to see increased risk of congestive heart failure in women with a prior history of preeclampsia. And again, thinking about the age of pregnancy is 30, you're starting to see it at about 15 to 20 years later. So the age of 45 or 50, pretty early. Dementia, again, we see an increased risk of dementia in women with a prior history of preeclampsia. Again, another vascular disorder. So dementia can be Alzheimer's type or multi-infarct type, which is a vascular disorder. And we certainly wouldn't be surprised if we saw increased vascular dementia in women with a prior history of preeclampsia. And again, you see that starting about 30 years after the index preeclampsia, so maybe around the age of 60. It's older, but it's way too young to be developing dementia. And all of these comorbidities put together mean that women with a prior history of preeclampsia don't live as long. There's an increased risk of total mortality in women with prior preeclampsia. Okay, and you know, I really think we can learn so much about pregnancy outcomes for so many reasons and how it impacts a woman's future risk. Again, the placenta really has one really important job. It is feeding and supplying blood to the developing fetus so that it can sustain a pregnancy long enough and it can grow a baby large enough. And so having preeclampsia in combination with either small for gestational age or preterm delivery is associated with many more mortalities or cardiovascular risk. This is looking at major coronary events there on the left. The blue is someone with normal pregnancy. The rust color is preeclampsia. The green color is preeclampsia plus small for gestational age. And purple is preeclampsia plus preterm delivery. And you can see there's an increase in major coronary events going from regular pregnancy, preeclampsia, plus small for gestational age, and about the same for preterm delivery. If we look over to the right at cardiovascular mortality, we actually see the highest cardiovascular mortality in those with preeclampsia and small for gestational age, the green bar. So again, we need to think about the placenta and pregnancy in general in terms of the vascular implications, and I think we can learn so much. Another important thing to remember about this slide is it's looking at a 10-year risk. And if you think about 30 as being the average age of having a baby, that's looking at risk at the age of 40, so pretty young. So what do we need to do? We need to follow up these women. We cannot just say, oh, we dodged a bullet there. Yay, healthy baby, your blood pressure's come down. Pat you on the back and I'll see you the next time you get pregnant. We have to know that these are women that need to be followed up for life. This is our assessment schema. So you all will see them at their postpartum visit. You'll see what their blood pressure is. If it is less than 130/80, which is the current definition of hypertension, that's great. Again, we are happy. Right now, everything looks okay, but we have to discuss with them the elevated risk of preeclampsia and future pregnancies, as you've heard. But we also have to discuss the elevated risk of future cardiovascular disease and how this is something that we really have to keep an eye on for the rest of their lives. Now, if the patients I see, their blood pressure is still above 130/80, and that happens much more commonly than I think you'd believe. I see a lot of these women. Then we have to start thinking about treating them with antihypertensive medications, and there's a number of considerations, some of them being whether they plan to get pregnant again, whether they plan to breastfeed. We have to discuss appropriate contraception because some birth control pills have been associated with slight increases in blood pressure. Probably should get some testing like an electrocardiogram. These women need to be followed up for any persistent laboratory abnormalities, and they need to know that they have to have regular screenings for cardiovascular disease, diabetes, and renal disease. There's an increased risk of diabetes and renal disease, as I showed you before, in women who've had prior preeclampsia. A lot of this can be done in the setting of the OBGYN or the primary care physician, but there are some people that need referral to a cardiologist, and I see many of these women. Now, I said 130/80 as the binge point for who is someone I need to follow more closely or not. But I want you to know that even though the definition of hypertension is less than 130/80, for a young, healthy woman, it should be much lower. Young, healthy women should have blood pressures in the 110/120 range and not higher. And this is actually from the new the new hypertension guidelines. They call anyone with a systolic blood pressure over 120 to 129 elevated blood pressure. The reason why is shown here. Each set of lines is a decade of life. So the 40s are in red, the 50s in orange, the 60s in blue, the 70s in black, and then the green is others. You can see as you hit a threshold of blood pressure of 120, there's a rapid rise to hypertension in every age range. Even though we say a blood pressure of 130/80 or less is normal, a blood pressure of 130/80 is not normal in a young, healthy woman, and those patients need to be followed very, very closely. Okay, so a history of preeclampsia increases the risk of future hypertension, ischemic heart disease, stroke, venous thromboembolism, and dementia, and death from any causes. The major contribution to all-cause mortality is cardiovascular disease. There's no increase in the risk of death from cancer. Women who have had preeclampsia early, less than 37 weeks of gestation in their first pregnancy, are more likely to have recurrent preeclampsia with a future pregnancy. If you have preeclampsia plus small for gestational age or preterm delivery, that does indicate an even higher risk population and poorer outcomes. Thank you so much for your attention. I will stop sharing now. Dr. Swelly?
Yes, our next presenter is Ms. Chanel Gibbs. So we're just going to give her a moment to get her screen up. Thank you.
Thank you. Good afternoon, everyone. I am honored to be in the presence of such esteemed presenters. I am a community member, a severe preeclampsia survivor, who is here to share the story of my journey with my birthing story and preeclampsia, and which ended in the loss of my daughter, Isabel, and we call her Bale. So I will just take a little time and present some things to share on behalf of myself and women like Amber Rose Isaac, Shazia Washington, and Nicole Thea, who recently were African American women who lost their lives during childbirth. So with that, I will start with Bale's story. And this presentation is basically about my journey and my fight for the care, for the life of myself and my daughter. There were some decisions that were made that I still question, but I've made with, and ultimately it led to the loss of Bale. I credit my mother being an RN with helping me to advocate for myself on my birthing journey, which led to the revelation that Bale was severely growth restricted, and also led to my emergency C-section, which saved my life and saved Bale's life and allowed us to love and enjoy her for the 4 months that she was with us. And so I'm just gonna move through the presentation here. And this is just a quote from me. So, better birthing outcomes are possible when all healthcare providers are trained to listen to Black mothers' wishes and concerns and act well before we're in crisis. So I'm just gonna step through just a couple of things that came up during my pregnancy. Bale was born at 27 weeks, just shy of 28. So very early, and I suffer from a severe form of preeclampsia. I also came into the pregnancy with a few risk factors. And sadly, during the course of my, my prenatal visits, which I made everyone, I expressed some concerns about how things were going, and preeclampsia never came up. So I never had any prehistory with hypertension. It developed during pregnancy, and preeclampsia and severe preeclampsia and all of the IUGR, micropreemie, severe RDS, these terms that I now know just came right before my emergency C-section. So I think it's helpful for women on the journey to know. And I hope to be somebody who can help explain that to others and share my story. So these are just some little key points that happened on my birthing journey. I was over 35, my first pregnancy. And so some of the things that were happening in my body, I didn't, quite understand or know how to articulate on a medical level. But I had an African-American midwife who I saw during all of my prenatal visits, never missed an appointment. And so one thing that I do want to share is that implicit bias and some of the things that we talk about as we advocate for Black women goes across the board, and everybody should be continuing to listen to us and our concerns as we go on the journey together. While I was pregnant, I expressed concern about my fundal height growth and my belly growing, and waved away by you know, the professionals. And at the growth scan, I had to verify what percentile she was in after doing some research. She was measuring a little small, so when I asked, they said the 21st percentile, and that was very scary for me. And so I was told that this was okay. I'm kind of a smaller person, and nobody, you know, it didn't raise any red flags. I asked more questions. A perinatal specialist said it was all right, and so we were moving forward. And that was always a concern for me during my pregnancy. At one of my last prenatal visits, I questioned my blood pressure increase. As it was rising, I said, oh, it seems a little weird that my blood pressure is kind of just steadily going up. And no, we don't worry about that unless they gave me the figure. In the absence of any follow-up on some of my questions, I was really adamant about advocating and making sure that before we hit that 28-week mark that we checked in on Belle's growth, just to make sure that everything was going okay, because I was just being reassured that everything was fine when I knew in my body that it wasn't okay. And so I requested, made some multiple calls, and sent, you know, an email to my provider and asked for a follow-up sonogram just to check in on the baby. Once I did that, I got my appointment, and I knew, as the sonographer, if I'm using the term correctly, was going over my belly, that something was terribly wrong. And they revealed to me that Belle had fallen from the 21st percentile in growth to the 3rd percentile. And that immediately I was to go up to labor and delivery. And I was wondering, labor and delivery, what does that mean? And then everything was revealed. There's severe preeclampsia. My blood pressure was through the roof by this point. And they were getting scheduled to deliver, if possible, maybe even that night. So all of this information came right then and there. Despite my risk factors for preeclampsia, it was never discussed during my prenatal visits. So the outcome of everything was that Belle was born just shy of 28 weeks. There was severe preeclampsia. There was severe growth restriction. There was our emergency C-section. My life was at risk. Her life was at risk, that we were hanging, you know, in the balance the whole time. Severe RDS because of Belle's lungs were not developed. There was a NICU battle, and Belle really fought courageously. We got to love her, so proud of her. But unfortunately, it ended with her passing away in January of this year. So she was born at 27 weeks, 465 grams. And everything that I still do is for her. So me doing this presentation and sharing my story wherever I can is a part of honoring her and sharing my story of kind of feeling unheard on my birthing journey by the medical professionals. And I hope that we're able to do something about that, and that the lives of countless women and babies, African American and people of color, we can share, we can save just by listening and taking a little more action before we get to these crisis levels where our lives are, completely at risk. And yeah, so that is my presentation. I thank you all. I'm going to stop sharing here and mute myself. Thank you.
Just before we go to our next presentation, I just can't help but stop just to say thank you, Chanel Gibbs, for sharing your story and for what you continue to do in service to others, despite all you've been through. Thank you. And now our final presentation by Mashariki Kudumu.
Hello, everyone. Thank you so much for having me. Thank you so much, Chanel, again, for sharing your story. And my name is Mashariki Kaduma. I'm with the March of Dimes. I'm the Maternal and Child Health Director for Greater Los Angeles. My presentation today really will marry both the presentations from the clinicians as well as the presentations from Chanel. I don't have any disclosures. These are my objectives. And March of Dimes, in case you don't know, is one of the largest and oldest national organizations really dedicated to mom and baby health. And we fight for the health of all moms and babies through advocacy, research, community, consumer, and provider education, and supporting families through the journey of pregnancy and birth, even when things do not go as planned. I want to level set today and sort of talk about prematurity as it relates to infant mortality. There's a lot of discussion around infant mortality, but prematurity is one of the #1 causes for infant mortality. And for us to really impact infant mortality, we have to decrease prematurity. And so the costs of prematurity are large, not only for families that have been impacted, just as Chanel shared her story, but for society at large. There's huge economic and educational and societal costs. So in California, the cost of prematurity is $3.6 billion, and that's billion with a B, dollars annually. And the cost of prematurity for each baby that's born premature is about $75,000 each year. And that's medical, social, and educational costs. And their long-term impact of prematurity includes cerebral palsy, intellectual disabilities, lung, breathing problems for the baby, blindness, and hearing loss. And just want to share some data as well to level set. And so in LA County, we're seeing that the preterm birth rate it's been going up in the last couple of years, and Black babies are born preterm at higher rates than other babies at about 50% more higher. The infant mortality rate for Black babies is high as well. And so as you can see in this graph, while other races, the preterm birth, the infant mortality rate is decreasing, for Black babies it has been increasing for recent years data that we have, and it's a rate that's 3 times higher than other babies. And for Black moms, this really should call us all to action. It's a maternal mortality rate for moms in LA County. And so even though maternal mortality is a rare occurrence, it doesn't happen as often, the impact is significant. And what we see with this slide is that Black moms die of a ratio that's about 4 to 6 times higher than other races and other moms. And this data shows that this is not about education, as we see that Black moms with graduate degrees, like some of our clinicians with higher education, they have a preterm birth rate and low birth rate that's higher than white women who've dropped out of high school. We also know that this is just not about health status. And so even when we look at conditions that impact our health, like obesity, Black women fare worse than white women. And so we know that preeclampsia increases the risk for preterm birth, as our clinicians discuss. Some of the data says that up to about 15% of all preterm births are related to preeclampsia. We know that the preeclampsia rates are increasing in Los Angeles County, and that Black women have higher rates of preeclampsia and are more likely to die of preeclampsia. And also too, that the healthcare costs for preeclampsia are huge. For mom and baby, it's about $2 billion with a B annually each year in terms of healthcare costs related to preeclampsia. And so as the doctors discuss around low-dose aspirin as being a preventative clinical intervention, low-dose aspirin is cheap, it's easy to access, but it's underutilized. And so at the March of Dimes, we wanted to understand this a little bit more. We wanted to understand what were some of the barriers for women in accessing clinical interventions to reduce preterm birth, like low-dose aspirin for preeclampsia. And we wanted to understand more about their patient experience. And so we had a series of focus groups, listening sessions, and interviews with Black moms who had a prior preterm birth, community-based organizations serving Black families, and clinicians providing prenatal care to Black pregnant and birthing people. And the reason why we have these three groups is that we understand that the reasons behind some of the adverse outcomes for Black women are multifactorial, as our clinicians discussed. And for us to really impact and improve health, we have to have a cross-sector approach, and we need all hands on deck. And so for us to be able to look at these partnerships and solutions, we really need these three groups. And so I wanted to share some of the findings as a way for us to think about what are some of the steps we can take to increasing access to care, quality of care, and reducing disparities. So for the moms, and this was just one of, I think that just sort of reinforces what Chanel talked about, that a lot of the moms that we talked with in our focus groups and our listening sessions, they didn't know that they were at risk for preterm birth, that their pregnancy was high risk until they were in the hospital in preterm labor or having an emergency C-section. And so they were unaware of some of the clinical interventions like low-dose aspirin or progesterone and never had a chance to access those. Many of the moms identified high levels of stress during pregnancy, and stress was related to societal and environmental, toxic stress being a Black woman in America, also to some of the emotional, and as well as finances, family problems, work. And so these all really kind of compound and really do, as Brandy talked about, really are sort of the wear and tear and the weathering on Black women that puts them at increased risk for some of the conditions that we are talking about. And also the moms talked about not feeling listened to, felt like they were being talked down to by their provider, even when they were presenting with life-threatening physical symptoms like swollen limbs. And one participant talked about how she was going to the doctor, concerned about her swollen limbs, being turned away, and then she went home and Googled her symptoms and saw that they were classic signs of preeclampsia, and she went to the emergency room and she was admitted. Her blood pressure was so high that the doctors told her that she had not come in, that they were afraid that she would have died at home. And she was really upset because when she learned about preeclampsia later after birth and how this can be prevented, the fact that she wasn't listened to was very upsetting to her. And these traumatic birth experiences have lasting impacts on moms. And so they talked about, not being able to heal that experience and not having lasting impact, but the traumatic births also to impact their ability to bond and to want more children after that. So this really is about healing families, healing moms, and healing our community. And so the more we think about how we're going to decrease these disparities and improve access and quality of care, it really is this call to community action and call to heal our communities. We talked with the community-based organizations. They acknowledged that they felt that the racial disparity in perinatal outcomes were a combination of racism, historical factors, and stress, as well as this unsupportive healthcare system. And they also thought that there was a lack of coordination between community-based organizations and clinical providers. It really sort of raised that up as a way to improve birth outcomes and community health when the organizations and the clinicians came together. And that's also too, like clinicians referring their patients to some of the community-based organizations that provide social support, like Black Infant Health, telling their patients about the community doula programs that we have through AAIMM and frontline doulas to provide them more social support during this time. And also the community-based organizations felt that medical professionals should be held more accountable for disrespectful and unresponsive care. And so the clinicians, so what I think is really interesting is that everyone, all the groups, moms, babies, clinicians, moms, babies, community organizations, and clinicians talked about the fact that Black women are experiencing high levels of stress. And they also talked about that they felt that the healthcare system was unwelcoming to Black women. There was a lack of emphasis on prevention, and that the way the medical system is set up and the way there's reimbursement with healthcare, that it really took time away from them being able to develop trust and rapport with their patients, to be able to really address some of the underlying health conditions and to spend more time on education and prevention. They also talked about wanting to do more around, in their own institutions, around addressing disparities and reducing them and improving access to care. But they didn't have the support from their institution or from the leadership. So whether or not their leadership didn't feel it was important, there was no funding for educational opportunities, as well, and having more chances to create, whether it's quality improvement projects as well. And then the clinicians were also frustrated when they felt like they would talk to patients about clinical interventions and they didn't accept or didn't adhere to them. And so to me, this goes back to the what the patients were talking about, feeling talked down, feeling not listened to. And so there really is a need to have more improved patient and provider education and more improved communication and emphasis on prevention. And so when that is able to happen, when that trust is developed and that rapport, and both parties feel like they're listened to, we're able to make some changes. And so what are some of the action steps that we can think of and do? And so March of Dimes, in partnership with AAIMM and Cherish Futures and with our clinical providers, really are wanting to spend some time the next year really sort of zeroing on preeclampsia and low-dose aspirin and how we can improve access to care. And so hosting webinars and in-services like we're having today with both clinicians, pharmacists, and the community. And one thing that's come up, I have a clinician who she would always tell the story about going to the pharmacist on the corners around her clinic and telling them about low-dose aspirin and providing education, because what would happen was that the patients would go with their prescriptions for low-dose aspirin and be told that they couldn't take it because it was contraindicated for pregnancy. And as the clinicians and doctors talked about before, it's not. And so this is a barrier, and doing more education with our pharmacists around these interventions and what the benefits are, and to make sure that women aren't turned away unnecessarily. And this is really important during this time of COVID, because pharmacists are part of a women's care team. And during this time of COVID, we don't want women unnecessarily have to go out and being turned away. and women are using their pharmacists more during this time of COVID-19. So this partnership in education is even more important. And so we're working with pharmacists not only to increase access and reduce barriers, and so we're thinking about our local pharmacists, but also to how are we working with the corporations, whether it's Walgreens or CVS, to make sure that there's some systems changes within their systems. And then outreaching to community clinics, because we hear too that some patients talk about never hearing about low-dose aspirin or preeclampsia from their clinicians. So wanting to make sure that everyone's on the same page and that there's information and education and how can we make sure that we're all, like I said, on the same page. Writing blogs and articles for community awareness. So that the community too has this information that they can go back to their clinicians. And then implicit bias trainings. And so March of Dimes is excited to roll out our implicit bias training that really is rooted in structural racism and does lift up. We start our training lifting up the story of Dr. Shalon Irving, who's a woman who died unnecessarily from preeclampsia and her health conditions after birth and not being listened to by her providers. And so really having, and as one person put in the chat, how do we talk about increased risk for women and all Black women being on low-dose aspirin in a way that is culturally appropriate, that's respectful, and that folks can hear, right? And some of that is looking at our own biases and our own stereotypes, and making sure that when we are talking with clinicians or meeting with their patients, that there really is this level of understanding and respect. And also really looking at advocacy and supporting Momnibus, which is a federal package of policies and legislation and bills aimed at reducing health disparities and improving birth outcomes for Black moms. Advocating for paid family leave and the expansion of maternal mental health. And so in California, beginning now August, moms who have Medi-Cal, who have had a diagnosis of a maternal mental health condition are eligible for up to 12 months of care for their mental health. And then lastly, when we talk about this relationship in terms of talking and communication, really are asking our providers to talk to their patients about low-dose aspirin, preeclampsia, and two, for patients to ask their provider, I heard about preeclampsia, am I at risk? What about low-dose aspirin? What about magnesium? What are some of the preventions? And so having this dialogue that goes both ways. And then finally, I just want to share some health, both for patient and provider education materials that March of Dimes has regarding preeclampsia that you can find on our website at marchofdimes.org or preeclampsia. We have a action sheet for patients that they can tear out and bring to the provider to help guide these conversations. We have a one-pager infographic that's easy to read for providers to use with patients around some of the signs and symptoms of preeclampsia. We have a blog that talks about preeclampsia and COVID-19 and what you should know. And then finally, we have revised our birth plan, and now we have a COVID-19 birth plan, and this really helps patients to navigate conversations with their providers around prenatal care, birth, as well as labor and delivery and postpartum care and breastfeeding during this time of COVID. Thank you so much, and I'm available if you ever want to reach out to talk about how we can partner and make sure that both the community, clinicians, that we're coming together to partner together to improve access to care, improve quality of care, and reduce disparities, and make sure that all our Black moms and babies have an opportunity to live, thrive, and have a joyous birth. Thank you.
Thank you very, very much for your presentation. I wanted to thank all of our speakers, Dr. Hines, Dr. Watson. I also wanted to thank our non-clinical speakers, Ms. Gibbs and Ms. Kadumu, to really give us a comprehensive view of preeclampsia. And it will enable all of us to be much more effective in advocating for patients and driving change. Now, at this moment in time, we are at 3:15 and we are only going to the bottom of the hour. There are great questions in the Q&A. I'm wondering if people have had a chance to look at them, or should we start with the unanswered questions? I think with our time left, I'm going to start with the unanswered questions. And we have some very important ones. And if you have other questions that we can't get to, please put them in the chat and we'll be able to get them. So let's start off with a high-level question that gets us all on the same page. Can anyone tell the audience what is currently being done in the state of California to eliminate racial disparities in maternal mortality?
Pick me.
Brandy, would you like to take the lead on that one?
It looks like Dr. Hines would like to respond.
Okay.
Okay, so this is Brandy with First 5LA. So statewide in California, there is definitely a coordinated effort to address Black infant and maternal mortality. So for example, at the state level, we have the California Perinatal Equity Initiative, which provides quite a bit of funding based on the amount of Black births that you have in your county, as well as a series of interventions that you can choose to fund in order to address infant and maternal mortality in a coordinated way. Here in Los Angeles County, we have the AAIMM Initiative, so the African American Infant and Maternal Mortality Prevention Initiative, which is a collaborative effort between public agencies such as First 5LA and the Department of Public Health, who lead the effort, alongside other public agencies such as DMH, DHS, our organizations such as the March of Dimes and the Association of Black Women Physicians, as well as CBOs such as the California Black Women's Health Project and Black Women for Wellness. And there is an effort to increase, expand, and improve interventions addressing Black infant and maternal mortality, such as doula care, home visitation, 17P, as well as an effort to make sure that the various stakeholders, such as medical providers, policymakers, and community members, are aware of the issue and understand how we can all serve as a village of support to address it. And so if you have more questions about what we're doing at LA County, please find us at blackinfantsandfamilies.org. And then also ABWP is becoming a partner in this effort, so please check out their website as well.
Okie doke. With the limited time, I'm going to skip around to questions. Please type any questions you have in the chat so that we can put them, ultimately publish them. But one question, and I don't know who wants to take it, is can one of the speakers please address the scientific evidence and clinical trials that support the impact of racism?
Well, this is Carol Watson. I can address what I know about racism in terms of inflammation and stress hormones. One of my colleagues, Michael Irwin at UCLA, who runs the Mindfulness Center, Mark, has done some studies to show that there is, in individuals exposed to racism, there is increase in inflammatory markers, increase in stress hormones, increase in a lot of things that we know that increase the risk for cardiovascular disease. I don't know about data on preeclampsia, but from the pathophysiology that we know, it sounds like it certainly would. I don't know, Dr. Hines, do you know, are you aware of any?
It appears that the gardener has shown up in the background. I was trying to turn off my mic. Just I can say quickly that I can speak from the Kaiser standpoint. There is a huge collaborative group in the region working on African-American patients, Hispanic patients, non-Hispanic white patients, and their outcomes for delivery. And Kaiser has a toolkit, as well as the California Medical Quality CMQCC HEMRIS kit. I mean, we use all of that in order to decrease the incidence, and what we have is an integrated system, right? Yet our outcomes still, we have disparities in our own group. So, you know, I've got a lot of information in my brain about what it means to be a Black woman and to be pregnant. But is somebody saying, I'm gonna do some research on how racism is impacting Black women in pregnancy? I don't think there is an exact study like that. There is a study that talks about what it means in the common life experiences that we have. It looks at socioeconomic status and the social determinants of health. And then they compare that to someone who is wealthier with more education and things like that, right? And then you look at that inside of the Kaiser system and say, shouldn't their outcomes be equal if they're getting aspirin at the time they need to, if they're getting 17-hydroxyprogesterone for a previous history of a preterm delivery, if they are in non-stress testing with higher level of surveillance and seeing the high-risk perinatologist, aren't they doing better if they're seeing Dr. Hines? Yeah, but there's still disparities. And the question is, well, what is that? It's racism. It's clear that in my own department of 22 physicians, there are those who say that they're treating everyone equally, and we know equal means providing everything the same, everything to everybody, but equity is making sure that you have what you need. And that's where the disparities, we could probably see a difference between those women who show up just being Black. They need more than those women who aren't. It just is. And if they prove to you that they are a lower risk pregnancy, despite everything that you're doing, or in addition to everything you're doing, then, but please recognize that if you start off by thinking that all of your Black patients and all your brown patients are likely to have some of these poorer outcomes, you do better than just assuming that you show me that it's a bad thing and now I've got to intervene. So I think it's important to ask those questions when you first start at the intake interview. And let me just put it out there, there's a lot of distrust with patients with regard to African American, I mean, just in the healthcare system. And to some extent, they got a reason. But when you tell me that you want all natural, I'm gonna get off quickly. All natural, people used to just all naturally die in pregnancy all the time. I can't accept that for us. I can't accept that naturally we should just deal with all that we brought into the pregnancy and recognize that's likely to give you a poor outcome. I'm gonna intervene. And I'm hoping that this information with all these wonderful people on this call is showing people that there is something we can do. And even when we do everything, it may not end up being perfect, but it's a whole lot better than assuming that it's going to be a bad outcome and there's nothing we can do. And I will now go back to mute.
So we're down to the last one or two questions. I want to ask a question that any of our participants can address. And I think, or I'm going to try to edit the question and so I can squeeze in a second one, is how do we communicate either as lay people to clinicians whose knowledge may be defective? How do clinicians communicate effectively to patients who may think that since everybody they know came out fine after a pregnancy? I'd like from both sides to talk about how do we more effectively communicate in order to improve outcomes. And I'll let whoever feels most comfortable take the lead. There must be a volunteer. Well, I'm going to say Sylvia's answer since everyone's being so courteous. The reason I'm in non-clinical medicine is I'm passionate about improving processes to improve outcomes. So Sylvia is going to go to an underserved community Monday and educate physicians about thinking about preeclampsia beyond just the folks who have hypertension. I'm going to be talking about the things we do before and after deliveries. And so I'm going to be changing a process to try to improve outcomes. And if someone doesn't volunteer to speak, I'm going to pick on somebody. So, well, I think, let's go ahead.
I was going to say, I think one thing that can happen, I think Dr. Hines gave some excellent examples, but I think from the patient perspective and the community perspective is for folks to share this information. So, you know, the people who are on this webinar who aren't clinicians, I see our doula partners, I see our community-based organization partners, share this information with your patients and your clients that you work with, your family, your cousins, your sisters, so that they know. And that for patients going into the clinic setting, write down your questions, because I think sometimes you have questions in your head, and once you get in there, you forget them. But write down your questions before you come in and be prepared. And if you don't get the answer that you don't understand, one, if they're telling you something you don't understand, and if you're not getting your questions answered, and you feel like something's really going on, then, speak up, ask for a supervisor, ask for someone else, but just make sure that that's heard. And if you feel like something's not right, go to the emergency room. Like, don't feel like you have to suffer. We know our bodies. If something's not right, really go to the emergency room. So those are some of the things that I would, and I don't know if Chanel,
yeah, Ms. Gibbs, I think,
own experience too, if she has input.
And Ms. Gibbs, I really thank you for telling us a very painful and powerful story. And with the last 5 minutes, I really think you should be the person that closes this educational seminar.
So much pressure.
Summary?
Well, yeah, I think through my experience, I learned to trust my instincts, trust my body, trust what I knew inherently that was going on. And in the absence of a doula, which I was, the day that I went into the hospital was the day that I was signing my contract with my doula. It was, yeah. So, trusting my instincts and challenging what was being told, challenging what I was being told to accept as normal and okay. And that was really important to me, because ultimately it ended up saving my life and allowing me to meet bail, because in a different scenario, we both could have been gone, had I waited a couple more weeks, or just, who knows what could have happened. So that revelation, and you hear it sometimes when people say trust your body and trust your instincts, but sometimes when you're being in the situation where the medical professionals are telling you things, reassuring you that things are okay, it's just it's hard to do sometimes. But that's what I'm here to share with women, is always, always ask for follow-up. Sometimes we're going to have to fight, sadly. We know as Black women, it doesn't end, on a birthing journey. And eventually the work that all of you wonderful women are doing is going to change that. And we just continue educating each other. Since my birth experience, I have taken a doula workshop. And I've just been very interested in knowing even more about the process and supporting women through the process and advocating for them, my sisters, my cousins, my friends, and just sharing my information has just become a passion for me. And sometimes when I, don't understand why things happened the way they did, I go back to doing this for bail, doing this for women who have lost their lives, doing this for women who are going to go through journeys and they need to hear from us, you know, because I think sometimes there's shame involved and there's so much trauma that a lot of women don't even share their stories. You know, they just shut down and they're not able to get, you know, the help or to even explain what happened, and it just eats us alive. And so, yeah, I'm educating myself as much as I can, and I'm just telling the story and supporting as many women as I can. And I don't know if that answered the question, but
well, that was an excellent answer to the question. And I had intended to shut my mouth because this is about other people, but there are a couple of things I need to say. As a person who's in non-clinical medicine, my passion is improving healthcare and outcomes. So when someone says, how do we decide we're entitled to good care? You do because you're paying for it. I will tell physicians in meetings, y'all are the hired help. So you don't need to beg somebody to give you good treatment. That's Sylvia's speech in many things. So you don't need to beg anyone. If you say physicians took the Hippocratic Oath, they have an ethical obligation to give you good care. Now, clearly getting that and talking to a defective audience and systemic racism, I'll spare you my rant on that topic because it's at the end of the hour. But there's nobody who should ever feel they're begging somebody to give them good care. And if you have health insurance in the state of California, you also have another route of advocacy under AB 12. You have the right to a second opinion for free. And so if you don't like what Fred's telling you for anything, look on your card and call your health plan. That's one way to get yourself heard. And if you and your friends don't know it, everybody should know those two things from the non-clinical person. So that's my, someone had some other question. I think I've answered it because we're 1 minute over. The Association of Black Women Physicians, we're very passionate to improving healthcare disparities. This year, we have been really focused on maternal morbidity and maternal outcomes. Our first talk was last month on implicit bias. We're going to be creating enduring materials, which is why this talk is being recorded. There will be other enduring materials up that we'll be posting after the conversation. I would like you to keep aware of our social media because we have 2 more talks left to give. Next month will be a discussion of preterm labor. And then we will finish in the month of October really talking about AB 2193 and peripartum depression and anxiety. So we would like you all to keep an eye on our webpage so you'll be able to participate at our upcoming lectures. I know there's a lot of things you could be otherwise doing on a Saturday. I think it's very important that you came, and I hope you finish this call being activated to make the most expensive healthcare system on the planet do better. So, I guess we should leave some space for folks to chat to make sure all questions that are available we can collect and answer in other forums. But I do want to thank you and be respectful for your time. And I look forward to meeting with you again to talk about preterm labor next month.
Should the presenters, panelists get off the call now, or we're officially, are we done?
I think we're going to try to see if there are any